We begin with Sarah, a newborn baby girl who has just entered the world. Sarah's birth was eagerly anticipated by her parents, especially her mother Maria. This is Maria's first pregnancy, and she had diligently attended all her prenatal appointments. Throughout her pregnancy, Maria maintained a healthy lifestyle. She ate a balanced diet, she engaged in regular exercise, she diligently took her prenatal vitamins. However, Sarah's birth was not without its complications. Maria's pregnancy had progressed smoothly until the third trimester. It was then that doctors noticed a decrease in the rate of fetal growth. This observation raised concerns about potential intrauterine growth restriction, a condition where a baby's growth slows down while still in the womb. Despite these concerns, Maria's pregnancy continued to term. However, when she went into labor, the medical team discovered that Sarah was in breech position. Due to this complication, Maria underwent a planned cesarean section to safely deliver her baby. The medical team diligently monitored both Maria and Sarah throughout the procedure. Upon delivery, Sarah weighed in at 5 pounds and 2 ounces. Her length was measured at 18 inches. These measurements immediately raised red flags indicating that Sarah was small for her gestational age. The medical team whisked Sarah away to the neonatal intensive care unit, or NICU. Their immediate priority was to assess her overall health and address any potential complications arising from her small size. The first assessment performed on any newborn is the APGAR score. This quick evaluation provides a snapshot of the baby's well-being immediately after birth. The APGAR score evaluates 5 critical areas: heart rate, respiratory effort, muscle tone, reflex irritability, and skin color. Each area receives a score of 0, 1, or 2, with a total score of 10 indicating the healthiest newborns. Sarah's APGAR scores were a bit concerning. She received a score of 6 at 1 minute after birth and a 7 at 5 minutes. These scores, while not critically low, indicated that Sarah needed close monitoring and additional support. In addition to the APGAR scores, the medical team conducted a thorough physical examination. They carefully measured Sarah's head circumference, chest circumference, and abdominal circumference. These measurements, when plotted on a growth chart, confirmed that Sarah's size fell below the 10th percentile for her gestational age. This finding solidified the initial concern that Sarah was indeed small for gestational age, often referred to as SGA. Small for gestational age, or SGA, is a term used to describe babies born at term, between 37 to 42 weeks of gestation, who are smaller than expected. Babies diagnosed with SGA typically have a birth weight below the 10th percentile for their gestational age. This means that out of 100 babies born at the same gestational age, the baby with SGA would be among the 10 smallest. Understanding the causes of SGA is crucial for providing appropriate care and predicting potential health outcomes. SGA can be categorized into 2 main types: constitutional SGA and pathological SGA. Constitutional SGA refers to babies who are small due to genetic factors. These babies are typically born to parents of smaller stature. While they may be small, they are considered healthy and follow their own growth curve. On the other hand, pathological SGA is a more concerning category. It indicates that the baby's growth was restricted due to factors affecting the pregnancy. These factors can include placental insufficiency, maternal health problems, infections, and genetic abnormalities. Babies with pathological SGA are at a higher risk of complications, both in the short term and later in life. Given Sarah's low birth weight and her APGAR scores, the medical team delved into Maria's prenatal history to uncover potential causes for Sarah's SGA. They reviewed Maria's medical records, paying close attention to her nutritional intake, stress levels, and access to prenatal care. Maria's prenatal records painted a picture of a healthy pregnancy. She diligently attended all her prenatal appointments, and her blood pressure and weight gain remained within healthy ranges. Her blood work showed no signs of infection or nutritional deficiencies. However, upon further questioning, the medical team uncovered a crucial piece of information. Maria revealed that she had traveled extensively during her second trimester. She had embarked on a business trip that involved long flights, changes in time zones, and exposure to different environments. While Maria had taken precautions, such as staying hydrated and resting when possible, the medical team acknowledged that the stress of travel and potential exposure to environmental factors could have played a role in Sarah's growth restriction. Section 5. The 20-week ultrasound. A normal scan, yet growth restrictions emerge. One of the puzzling aspects of Sarah's case was that her 20-week ultrasound had been completely normal. This routine ultrasound, often referred to as the anatomy scan, is crucial for assessing fetal development and detecting any major abnormalities. Maria's 20-week ultrasound had shown no signs of fetal growth restriction or any structural abnormalities. So, how could Sarah's growth restriction have emerged later in the pregnancy, despite a normal 20-week scan? The answer lies in the fact that fetal growth is a dynamic process, and factors influencing growth can change throughout pregnancy. While the 20-week ultrasound provides a valuable snapshot of fetal development, it cannot predict future growth patterns. In Sarah's case, it's possible that the factors contributing to her growth restriction, such as maternal stress or environmental exposures, came into play after the 20-week mark. Additionally, certain placental problems which can restrict nutrient and oxygen flow to the fetus may not be apparent on an ultrasound, but can still impact fetal growth later in pregnancy. Section 6. Asymmetric Growth, Deciphering the Clues of Fetal Development. As the medical team continued to assess Sarah, they noticed a particular pattern in her growth restriction: asymmetric growth. This term describes a situation where the baby's head and brain have grown at a normal rate, while the abdomen and other organs are disproportionately smaller. Asymmetric growth is often seen in cases of SGA, particularly when the underlying cause is placental insufficiency. In situations where the placenta is not functioning optimally, the fetus may prioritize blood flow and nutrients to the brain, ensuring its development at the expense of other organs. This prioritization is a survival mechanism that helps protect the developing brain, even in the face of limited resources. In Sarah's case, the presence of asymmetric growth provided further clues about the potential causes of her SGA. It suggested that factors affecting placental function later in the pregnancy may have played a role in restricting her growth. Section 7. The Ballard Score, Confirming Sarah's Gestational Age. To ensure they were providing the most appropriate care for Sarah, the medical team needed to confirm her gestational age accurately. While Maria had a reliable menstrual history, and her prenatal ultrasounds had been consistent, there was still a slight chance that Sarah was, in fact, premature rather than just small for her gestational age. To determine Sarah's gestational age with more certainty, the medical team used a tool called the Ballard Score. This assessment tool evaluates a newborn's physical and neuromuscular maturity, providing a more accurate estimate of gestational age than relying solely on the date of the last menstrual period. The Ballard Score examines 6 physical characteristics: skin texture, lanugo, fine hair covering the body, plantar creases, creases on the soles of the feet, breast bud size, ear cartilage firmness, and genitalia development. Each characteristic receives a score, and the total score corresponds to a gestational age. In Sarah's case, the Ballard Score confirmed that she was indeed a term infant, meaning she had completed the full 37 to 42 weeks of gestation. This finding ruled out prematurity as a contributing factor to her small size, further solidifying the diagnosis of SGA. Section 8. Maternal History, Unveiling Potential Influences on Sarah's Health. The medical team continued to explore Maria's medical history for any factors that might have contributed to Sarah's SGA. While Maria herself was healthy, they discovered that she had a family history of preeclampsia, a pregnancy complication characterized by high blood pressure and protein in the urine. Although Maria did not exhibit any signs of preeclampsia during her pregnancy, the family history raised a subtle concern. Preeclampsia can sometimes develop without obvious symptoms, and even mild cases can restrict fetal growth by affecting placental function. The medical team acknowledged that the family history of preeclampsia, coupled with Maria's extensive travel during the second trimester, could have subtly but significantly impacted Sarah's growth trajectory. Section 9. Sarah's Future, Postnatal Care, and the Path Ahead. With a clearer understanding of Sarah's condition and potential contributing factors, the medical team focused on providing her with the best possible postnatal care. Their immediate priorities were to monitor her closely for any complications associated with SGA, such as low blood sugar, hypoglycemia, difficulty maintaining body temperature, and feeding problems. Sarah remained in the NICU for several days, receiving specialized care and support. She underwent regular blood sugar checks, was placed in an incubator to regulate her body temperature, and received feeding assistance to ensure she was gaining weight appropriately. The medical team also educated Maria on the importance of frequent feedings and skin-to-skin contact, kangaroo care, to promote Sarah's growth and development. Beyond the immediate postnatal period, the medical team emphasized the importance of long-term follow-up care for Sarah. Babies born with SGA, even those who appear healthy at birth, are at an increased risk of certain health problems later in life. These can include learning disabilities, developmental delays, obesity, and chronic diseases such as diabetes and heart disease. To monitor Sarah's progress and address any potential issues early on, the medical team recommended regular checkups with her pediatrician, as well as referrals to specialists such as a developmental pediatrician or endocrinologist if needed. They also stressed the importance of providing Sarah with a nurturing and stimulating environment to support her overall development.